Hi, this is Venkata, one of the interventional stroke neurologists over at Essentia Health in Fargo. I am part of the Lifeline Stroke Physician Advisory through ND Mission Lifeline, and I sit on the committee developing North Dakota State acute stroke guidelines. And here I will try to present the new guidelines that we came up with. Hopefully this will help our physicians get through our stroke patients. All right, so here is the first slide. I'm sure you have access to the visuals for this. This is our previous acute stroke guidelines, and this will be replaced by our new acute stroke treatment guidelines that you have in front of you right now. The way we organize this is based on the timeline and based on the type of stroke that you're going to be seeing. We will walk you through this the next 10-15 minutes as best as we can. It's organized from 0 to 15 minutes. What is that you're expected or guided to do? 15 minutes to 45 minutes, 45 to 60 minutes. Therefore, the first 1 hour of this golden hour time frame where we can help our stroke patients. So I'll walk you through this one step at a time. Majority of these guidelines are not simply pulled from thin air. These are the guidelines that were published by the American Heart Association. These are the most recent current guidelines based on evidence-based medicine and recently published data. The same. And this is the group of American Heart Association Stroke Council that we have to acknowledge and thank for develop this. Again, I'm echoing what I had said earlier. Yes, this is evidence-based medicine, and one may ask, what kind of evidence? What is the level of evidence? So basically, evidence-based medicine is categorized into strength of recommendation and level of evidence. There you have it on your left side, where the class of recommendation would be based on the level of evidence. Either it will be class 1 evidence, which would be the strongest evidence for a certain recommendation, which is where it's clear that the benefit of such recommendation clearly is significantly better than the risk. And it goes down from class 1 to class 1A, class 2, class 2A, class 2B, class 3. And when we talk about class 3, where we're talking about the risk is outweighing the benefit, meaning that the recommendation is a harm. And on your right-hand side, we talk about the level of evidence. Level A evidence is the strongest level of evidence based on multiple randomized clinical trials, suggesting that that certain recommendation or treatment plan has been vetted from multiple randomized controlled trials and recommended that we follow that. And similarly, it goes from level A to level B with one randomized controlled trial, which is recognized as B-R, and level B, non-randomized trial, level C, and it goes all the way down to level C, which would be basically an expert opinion. Now, moving on to the next step, which is the stroke assessment. And I'm pretty sure you're all, the listeners are pretty familiar with these pre-hospital stroke scales that have been pretty frequently used, widely used, I should say. And what this is simply a yes or no questionnaire. It's not a graded score. It involves you basically checking 3 things: facial droop, arm drift, and abnormal speech. And if the answer is yes to any of these, is someone having a facial droop, is someone having weakness in the arm, which is reflected as a drift in the arm, or abnormal speech, where they can speak or they cannot speak, but they can't speak or their speech is garbled, or they have slurred speech. Any of the things, if they have one abnormal thing, it is 72% likely that they're having a stroke, and this helps to differentiate, recognize patients at a time. The problem, I shouldn't say problem is a strong word. Basically, what was happening with Cincinnati Stroke Scale and the FAST score is that we were missing a significant chunk of a subtype of stroke, which involves the posterior circulation. And what I mean by posterior circulation is the vertebral arteries, the basilar artery, because when you have a stroke involving the cerebellum or the posterior fossa, These symptoms can be missed based on the Cincinnati score because this does not involve the dizziness, which is a huge part of the posterior circulation symptoms, along with the double vision. So it would be mostly dizziness, visual problem. So therefore, this was this observational study that showed that if you were to use FAST score or Cincinnati score, you would be missing about 15% of the strokes coming to your emergency room. And there was a fix for this that came up with, and that leads us to our new stroke assessment, which would actually add a few things to the FAST score. And funny enough, it will be something called BFAST. And what it is we have added a B and an E to the FAST score that was already in place before, to make it much more easier and easy to remember, and so forth. And B stands for balance. If someone complains of loss of balance or coordination, which is sudden in onset, that should trigger you that this patient may be having a stroke, along with E, which represents an eye, double vision or loss of vision, should trigger that this patient is having an acute stroke symptom, and therefore trigger the pathway for the same. The rest of the FAST remains the same: facial drooping, arm weakness, speech difficulty, and it's time to activate the stroke response. And how do you check the balance? I know I touched on this very briefly earlier. A couple of things that someone would be complaining to you about: if the patient complains that he's having trouble walking, leering to one side, and unsteady on their feet, falling backwards, certainly that would be an indication that they're having trouble. But on your exam, you should certainly examine the finger to nose testing, which is representative of the posterior fossa, along with heel to shin test. If any of these abnormal, plus or minus the dizziness or loss of balance, that should prompt that this patient is having a posterior move to the stroke pathway. We talked about this. If someone is complaining of double vision, and I think this is the key piece here, it's not just loss of vision. Double vision is what suggests the ominous sign. Trouble seeing, obviously, loss of vision on one side or the other should trigger that. And on your exam, you should be checking each eye on 4 quadrants. And if they have any quadrant or the whole quadrant missing, that should be suggestive of, again, a stroke that happened in the posterior fossa in the visual pathway, triggering the stroke pathway. Face, we are talking about a facial droop. This is something that you see quite commonly. I don't have to go ad nauseum about this. If you were to ask the patient to smile and they have a droopiness on one side, or even if they complain of numbness on one side despite activating the face symmetrically, that should definitely trigger stroke activation. Same thing with the arm. Here, what we're trying to do is have them pick their arm up, both your arms up, and if there's a drift on one side, or if they're unable to move the arm at all, again, that should trigger the stroke pathway. Now, here's where it can get slightly tricky. Should we consider thick speech as a stroke symptom? Yes, absolutely. They are still able to speak. You're still able to understand, although it's difficult for you to understand during your assessment, but certainly they're able to make to say the right words and follow the questionnaire or your command properly. Dysarthria would also be considered as a stroke symptom, along with someone who's unable to speak at all, unable to understand, or if they're speaking and their speech doesn't make sense with garbled words or general words, then that should trigger your stroke pathway as well. And yeah, this is the time where you activate the stroke pathway and move to the next level. In the first 15 minutes, so here's where we get into the stroke pathway where our clock is on. Let's say the stroke activation is complete, and what do you do in the first 15 minutes? I think the most important thing that we often forget about is we need to know when the patient was seen to be last known well. It's not when the patient was seen with those symptoms. Certainly, yeah, this is where a lot of things get confused. Oh, I have seen my husband at 3 p.m. With the facial droop, but that doesn't count. We have to know, unless he or she was with the patient all along, and this happened in front of their eyes, that works. However, what we have to know is if they were not with their loved one, or if there was a bystander who was not present at the time these symptoms were happening and it was seen at the time, we have to have a reliable history as to when the patient was last known to be completely normal. And I cannot stress you how important this is for our first responders to collect this data. And if the patient is able to give that information to you, that's the best case scenario. They are not aphasic. They're completely with it. They say, yes, at 3 p.m., I looked at the clock, I looked at my watch, and I started feeling numbness in my arm. And next thing you know, I couldn't move my arm. And that is your the most reliable source of information. Now, if that's not the case, then we may have to talk to multiple people. It could be the bystanders. It could be, if it's an in-house stroke, it could be the RN. It could be the therapist. It could be the physician. It could be the family who is sitting next to the patient more than anybody else. So it never hurts to confirm the last known well status with multiple sources, so we know we're doing we have the accurate information. So what we can't have happen is someone saying, well, I know this has happened a few minutes ago or 30 minutes ago. We cannot have speculative information here. We really need accurate information. And as we go forward, you'll know why this is very important. Because we have a certain time frame that we can give this Tipless or the clot-busting medicine based on the guidelines. And that's why it's important for us to have this accurate last known well status. So this is often gets talked about. Let's say someone comes to the emergency room, or this is an in-house stroke. They come in with numbness or weakness on one side, and you go assess the patient, and they're completely normal. Well, then the NIH stroke scale is 0. They have completely returned to their baseline, and you go back doing whatever you were doing, and then the nurse calls you and says, hey, this patient is not moving his left side again. This is 3 hours after he presented to the emergency room, or 2.5 hours after he presented to the emergency room. Now, the question always asks, well, when was the last known normal? Is it when the first time the symptoms started, or does the clock reset because he has complete resolution of symptoms? The answer to the question is every time the patient has complete resolution of symptoms, the clock resets, meaning the clock goes back to 0. If you're called 2 hours after the first assessment and he develops symptoms, then yes, he's still within the time frame for Tipless or the thrombolytic therapy. So therefore, we should consider the patient for thrombolytic. So what else do we do in the first 15 minutes? It's crucial, and it's very important that we consider getting the patient to the CAT scan as soon as we can, because that's where the money is. We ought to be able to see if there's a bleeding in the brain or whatnot. Patient. Now, along with that, while you're waiting for the CAT scan, while the room is being ready and anything else is happening, there are certain things that you want to consider doing in the interim or alongside, which would be activating the transport to go to the CAT scan, back and forth. Assess vital signs, very important. Repeat every 15 minutes, along with neurochecks. A quick bedside finger stick would help, especially if they're hypoglycemic. Then the treatment path would be different, and you have an answer as to why someone is drowsy or confused. It's not a stroke, it's probably hypoglycemia, and hook them up to the continuous telemetry monitoring. And if you can assess and complete an NIH stroke scale, that will be very important. But again, the idea is not to delay the CAT scan, but certainly move forward with as much as you can while you're waiting for things to happen. Now, just to reiterate, getting an NIH stroke scale assessment as soon as you can is a class 1 recommendation and level B recommendation as well. It's a strong recommendation, so therefore we should be doing this. What else can we do within the first 15 minutes? Certainly oxygen therapy if the SATs are less than 94%, and if the SATs show more than 94%, it is not recommended that we give them oxygen at this time. Obviously, keep the patient NPO, including meds and ice chips before. The first thing we have to assess in these patients is swallow before we give anything. These are the patients that are at very high risk for aspiration pneumonia, aspiration, etc. And again, think about putting 2 large IVs. 18 gauge would be perfect. This will help you eventually if you have to put in a CT angiogram and so forth. If you can't, at least get 118 and 120, I would suggest, and a normal saline to keep it open. Again, the idea here is not to delay the CAT scan for whatever reason. So get the CAT scan as soon as you can, because that will drive your pathway as to what this patient needs. So now we move from to the next step, which is 15 to 45 minutes. This is probably the most crucial time if someone is a TPA eligible or Tipless eligible. Now you have your CAT scan. The goal is to make sure we get the CAT scan within 25 minutes of the patient's patient. And please, this is extremely important for our radiology team to report the CAT scan back, whether or not they see a hemorrhage. Is it a unrevealing, unremarkable CAT scan? So you can proceed with the next steps. And certainly sending quick set of labs that includes your basic CBC, complete blood count, platelets, certain INR, coag panel, which involves PTT and INR, basic metabolic panel, and a troponin check would certainly help. And if someone is of childbearing age, young females, certainly a pregnancy test should help. This would be crucial for us to determine whether or not we can entertain giving Tipless if such is. Again, a 12 lead EKG, if it fits the time window, and if it's not delaying things. And again, you would know why I'm saying getting an accurate weight. It is important because the Tipless is a weight-based protocol. So a lot of hospitals have done weighing the patient on the way to the CAT scan or on the way back from the CAT scan. So whatever suits the hospital, whatever based on your resources, certainly weighing the patient is going to be have to be done in this time. So the recommendation is class 1 for both obtaining a non-contrast CT scan, and this has to be at least done within 20 minutes, and sooner the better. And most hospitals, if the resources are favorable, would bring the patient directly from the EMS gurney to the CAT scan, get the CAT scan, and bring them out. So therefore, you will fulfill that criteria for 20 minutes. And it's going to be very important for us to push the Tipless medication. Again, one thing that's very important here is just talked about getting the whole set of labs, but the guidelines have changed. It is a class 1 and a strong recommendation that we do not have to wait for any labs to come back prior to initiating Tipless therapy, if such is indicated, other than just obtaining blood glucose. So meaning if someone were to have a normal blood glucose on the finger, you can proceed with TPA. You do not have to wait for the platelets. You do not have to wait for INR, etc. The only caveat being, if someone is on Coumadin, obviously you will have to wait for the INR to make sure they're less than 1.7 to proceed with the next step. And another reason to wait for platelets would be if someone has a known thrombocytopenic condition, or someone is liver failure or cirrhosis or and such, or hemodialysis patients sometimes can have low platelet count. So keep those in mind, and unless you think you have to wait for platelet count in these few scenarios, you should be able to proceed with giving Tipless just with the finger stick. A baseline ECG could probably help, but certainly should not delay giving Tipless. And again, the same thing with troponin assessment as well. So what happens? So the CT results are in. We have the goal of the goal of getting the CT by the time they hit the door is 25 minutes or 20 minutes, and you should have a read by 45 minutes. And by now you have a clinical assessment. You have a CT scan that's read, and now you know. So what's on the CAT scan? Are there any findings that are suggestive of a stroke already that is evolving? Or is it unrevealing, unremarkable? Is there a hemorrhage? And depending on what you see above, let's say you see a hemorrhage, obviously you'll have to talk to the neurologist for further recommendations. And if it's unremarkable, certainly this would be a candidate for Tipless. And if there's a large stroke that is already in place or evolving on the CAT scan, certainly a call to the neurologist would help at this time. The other things that you want to think about in this time frame is perhaps this is a patient that may need to be transferred for further care after Altiplase, or maybe they have a large vessel occlusion and they need thrombectomy. So you should be thinking about arranging transportation plans at this time. In a worst case scenario, they don't need to be transported, therefore you can cancel it, but you don't want to miss the time and add more timing to having to plan this and call and so forth. So a little bit of preemptive activation here probably doesn't hurt. Now, if the patient is ruled ineligible for IV Altiplase for whatever reason, then certainly the next step would be to control their blood pressure. And this is the time where a call to the neurologist would probably help in further management of the patient. And if the CT is negative for for hemorrhage or any other acute findings, which we talked about earlier, a normal or unremarkable, unrevealing CAT scan, then we are proceeding with the checklist for this is the kind of patient that comes in with stroke symptoms within the time frame of 3 hours or 4.5 hours, depending on the kind of patient that we're talking about. Normal CAT scan, or at least unremarkable for acute abnormalities. Now we proceed to the next level where we check the eligibility for Altiplase. What we have here is an inclusion and exclusion criteria for Altiplase within 3 hours or within 4.5 hours. This has been revised because a lot of this exclusion criteria has been thrown out from the time the TPS has been recommended as standard of care in 1996. That's 20 years of exclusion criteria, and a bunch of these are thrown out, and we're coming up with this new checklist, which you should be receiving very soon. So the idea here is the Altiplase dosing is 0.9 milligrams per kilogram. So if you decide the patient is eligible for Altiplase, or if the neurologist decides the same, it's important for us to have an idea of what the dose is at 0.9 milligrams per kilogram. And regardless of the weight, the max dose you can give is 90 milligrams. Let's say someone is, well, it's 0.9, 150 kilos. We're not going to give 0.9 times 150. It's maxed at 90 milligrams. And you should remember that only 10% of this entire dose is given as a bolus over 1 minute, followed by the rest of medication run over 1 hour. And the indications here, there's a brief indication that lists about within 3 hours. Certainly patients who are either above or below 80 years, it doesn't matter. If they're within 3 hours, they are eligible considering they fulfill the inclusion and exclusion criteria. However, the exclusion criteria is slightly more strict for patients hours. These patients have to be certainly within 80 years of age. They cannot be diabetic and have a prior stroke, and their NIH stroke still has to be less than 5, and they cannot be on an oral anticoagulant regardless of time. It's important to keep this in mind, that the exclusion criteria is different for the extended window, which falls between 3.5 to 4.5 hours for Altiplase. So certainly, it is very clear at this point that the combination treatment, based on all the clinical trials that were published since 2014, about 6 or 7 of them, the randomized trials, the combination treatment of Altiplase followed by endovascular mechanical thrombectomy, if such was to be indicated, is the pathway and is the recommended pathway for these patients. You should not be refusing or denying someone IV Altiplase, even if they have a large vessel occlusion and you think this patient benefits from thrombectomy. The combination treatment is the one, IV Altiplase followed by endovascular mechanical thrombectomy is the standard of care. And certainly, this is the time where we have to talk about, yeah, your patient has received Altiplase. Is the site capable of doing CT angiogram or not? And if you are able to do a CT angiogram, the next step would be for you to send the patient for a CT angiogram of the head and neck. And certainly, if there's a large vessel occlusion in the form of left carotid artery occlusion or middle cerebral artery occlusion, vertebral artery occlusion or basilar artery occlusion, intercerebral artery occlusion, so on and so forth, these patients are the ones that will benefit from further invasive management in the form of endovascular mechanothrombectomy. So therefore, you would have to transfer these patients to a higher level center where these are available for your patients. So as you give TPA, as you start giving TPA, you should be thinking about the next step, which would be, is my patient someone who would benefit from endovascular thrombectomy? And if so, I should proceed with the CT angiogram and determine that eligibility. I think this is basically, we just talked about this. This slide reiterates the dose of IV Altiplase, which is 0.9 milligrams per kilogram, to a max dose of 90 milligrams. And 10% of it is a bolus dose, remainder of the medication run over 60 minutes. And here's the last thing that you have to keep in mind. So there is a dead space in the tubing that this medication goes through. So therefore, it is recommended that once the Altiplase is finished, you have to follow it up with a 50 ml of normal saline, 0.9 normal saline at the same rate that you have given Altiplase earlier. This is to ensure that whatever medication was left in the tubing dead space is actually going into the patient and accounted for. Very important. This is something that often gets missed, so keep that in mind. So what do we do? So now your patient has gotten IV Altiplase. You have achieved the goal of giving it within 45 minutes, which is great. So what are my next steps? So you ought to be thinking about, okay, the Altiplase is given. What are the ominous things that can happen to my patient? If they get better, that's great, but they can also get worse. And why would they get worse? Well, they could have hemorrhagic conversion, which is one of the most ominous and worrisome complication of giving Altiplase. It can happen in 6% of your patients. So therefore, there is a list of things that are suggested to form of examination to stay on top of this. And the suggested guidelines are that the vital signs and neurochecks are the most important things that will give you an idea if something is going wrong or something is getting better. So the suggestion is that, or at least the recommendation is that every 15 minutes during the infusion. So that will be over an hour, 4 assessments during the infusion, and then followed by, and then this is immediately followed by Q15 times 2 hours, the vital signs and neurochecks, and then it just gets expanded to 30 minutes, Q 30 minutes times 6 hours, and then followed by Q hourly, every hour, neurochecks and vital signs. The idea here, obviously, is to pick up any worsening of the symptoms, and if so, get an immediate CAT scan to see if there's any hemorrhagic conversion or if anything else ominous is happening. What is important, another important thing right after giving Altiplase is make sure that the blood pressure management is in place, the protocol is in place, and the recommendation is that once you start giving TPA, or even before giving TPA, the blood pressure has to be maintained less than 180 systolic and over 105 diastolic at all cost. And we'll go over the medications that are recommended in the next couple of slides. And certainly we talked about this. If you've started TPA, the next thing is, and the symptoms, if these symptoms are within 24 hours, whether or not you give TPA or not, it is important for you to consider doing a CT angiogram of the head and neck in case they have a large vessel occlusion. And if they fall beyond the 4.5 hours where you can give the Altiplase to them, you should certainly keep an eye out for a possible endovascular hemorrhagectomy, which can be offered to patients with large vessel occlusion up to 24 hours. Very, very important for you to remember this. Remember, 24 hours endovascular mechanical thrombectomy can be done up to 24 hours in select patients. Certainly no anticoagulation or antiplatelet therapy for 24 hours after giving Altiplase, and an NIH stroke scale post-infusion could be documented. What do we do with these patients where they are non-IV Altiplase eligible? These are the kind of patients that either they fall outside of the window 3 to 4.5 hours or beyond 4.5 hours. As I had said on my previous slide, please think of large vessel occlusions on all the patients that present to the emergency room within 4 hours. And the best way to assess this is to get a CT angiogram of the head and neck. And you do CT angiogram of the head and neck on all patients that come to the hospital or the emergency room within 24 hours with stroke-like symptoms? Well, yes and no, but certainly there are a few things that could help you pick those patients that would probably have high likelihood of large vessel occlusion. And what are those? The NIH stroke scale assessment, which is something that you would use in your daily day-to-day assessments. If your patient were to have an NIH stroke scale of over a 6, it is highly suggested that they may have a large vessel occlusion. Therefore, you should certainly obtain a CT angiogram while they are in the emergency room in case they need to be transferred. And what else do you have? Well, we'll elaborate a little bit on another stroke scale, which is being rampantly used as a pre-hospital stroke scale, which is FAST-ED. Remember, this is not the same as BFAST. This is something else to identify large vessel strokes. We'll go over in a little bit detail in the next couple of slides. FAST-ED score of over a 4 is also suggestive that your patient may have a large occlusion, and therefore you have angiogram. And what else? Certainly, any stroke, any clinical presentation that involves or suggests a cortical involvement. And what is a cortical involvement? If someone comes in with aphasia or neglect on one side or the other, a visual field or eyes deviated to one side or the other, these are also very suggestive of possible large vessel occlusion. So use these criteria to help you figure out if your patient needs CT or not. And what is FAST-ED? I promised you I was going to talk about FAST-ED as well. FAST is something that you're quite familiar with. The facial droop, the arm, whether or not someone has arm weakness or not, arm drift, speech, and time to activate stroke. And what we have added here is the eye deviation. If they have forced eye deviation to one side or the other, certainly that will help you figure out if your patient is having a large vessel occlusion or not. And D stands for denial or neglect. If your patient is having a sensory neglect, which would mean that if you're touching both arms or both legs and they can only feel on one side, that's double simultaneous stimulation, or they're completely ignoring their one side, then you would say that they have denial or neglect. Now, they have put together a FAST-ED score is almost like an NIH stroke scale. It's comparable. It's a scale, obviously, and you can see facial paralysis. It's scored between 0 and 1. Arm weakness is scored between 0 and 2, as opposed to 0 to 3 and 4 in NIH stroke scale. Speed changes. If you have global aphasia, it goes either from 0, 1 to 2. Same thing with eye deviation. If you have forced gaze deviation, it's scored at 2. Denial, neglect, as we talked about, double simultaneous stimulation versus not able to identify, it goes from 0 to 2. So for the most part, all 6 or the 5 assessments that you have go from 0 to 2. And if you were to score a FAST-ED and their score goes more than 4, it's very important for you to recognize that there's a 60% chance of your patient having large vessel occlusion. And these are the kind of patients that needs your immediate attention. And I wouldn't discount the patients who have a lesser score like 2 to 3. Even those patients have a 30%. So I would recommend that you consider getting a large vessel occlusion study in the CT angiogram if your organization has the capacity to do it. And if not, I would certainly encourage you to consider transferring these patients out as soon as you can, so they can get the proper, they can get the appropriate studies done as soon as they can. Now, to help you with the FAST-ED, I know we walked through it very quickly. You have this app where you can download Join Triage, and it will help you put the data in for FAST-ED and give you a score, whether or not it's a 2, a 3, or 4, or 5. Very easy to use. Keep your eye out for this, and maybe you can download this and help you score your patients. So what do we do with non-IV TPA patients, eligible patients? So these are the kind of patients where they have a minor stroke. You have done a CT angiogram. They don't have a large vessel occlusion. They do not present within the 4.5 hours, or they do present within 4.5 hours. They have exclusion criteria. What do I do with these patients? Well, this is the type of patient that you will have to talk to your neurologist to see if they're comfortable admitting the patient to their service and get MRI of the brain and whether or not you have those kind of services or not. So the next category of patients that you will come across for stroke activation is a hemorrhagic patient. So these are the patients where there's a bleed, a subdural, epidural, which is axial, or it could be intracerebral hemorrhage or a subarachnoid hemorrhage. So there's all these kinds of patients that come in with bleeds. The first and the most important thing for these patients is attention to the blood pressure. If their blood pressure is over is at 150 to 220, the recommendation is that you bring their blood pressure down to less than 140 over 90 as soon as you can. And we'll walk you through the blood pressure medications that are recommended or suggested. And certainly if the blood pressure is over 220, this will be a time where you talk to your neurosurgeon or the neurologist to see how quickly they want to bring it down. Maybe 20% at a time would be probably suggested, but certainly a conversation with your specialist would help. One of the important things about hemorrhagic patients is whether or not your patient is on an oral anticoagulant. And clearly the idea here is if your patient is taking Coumadin or one of the neuro anticoagulants, you should focus your attention on getting these patients to reversal agents as soon as you can, whether or not it's the FFP or the cryo or factor 7A, depending on what agents they're using, or the most recent reversal agents like crack spine, et cetera. Because now you see all these kind of patients with newer oral anticoagulants that have specific reversal agents that you may have access or may not have access to. So I would certainly recommend that the first thing you consider is reversing these coagulants as soon as you can, and keep the head end at 30 degrees to decrease the intracranial pressure, and certainly anti-seizure medications and any perhaps may help in your patients, but certainly a discussion with your neurologist or neurosurgeon would help. Some of these patients may actually need external ventricular drain placements and so on and so forth if it's a subarachnoid hemorrhage. And the discussion again with your primary, with your specialist would help. Medical management of in the form of osmotherapy for raised intracranial pressure, whether or not it's mannitol, hypertonic saline, if you have access to it and available, things that you should be discussing with your specialist there. As we talked about earlier, you have an ischemic stroke patient that is high blood pressure. What do you do? What is the recommendation for these for the blood pressure management? What do you do for blood pressure management? So if you have a hemorrhagic patient that needs who has a high blood pressure, you want to bring it down. Certainly, a good start would be for you to give labetalol 10 milligrams or 20 milligrams and repeat it over 1 or 2 minutes and see if that helps. If not, certainly as you do that, it's probably worth considering a preparation of nicardipine drip. And you can start it at 5 milligrams an hour and titrate it up to 2.5 milligrams an hour to the highest level of 15 milligrams. Usually this helps. And if it doesn't, you may have to consider adding other medications like hydralazine and enalapril or clevidipine, whichever suits you, whichever is available. And again, this is one time where we have to talk about you have a patient who is IV all Tipless eligible, except that they have high blood pressure, and you can't give it unless you bring them down to less than 185 over 100, 110. And this is where I would be really aggressive. Push them and see if you can bring it down so you can save some time and give the medication. If not, start the nicardipine drip as soon as you can, and the blood pressure will go down very quickly, and you will be able to start the TPA. Now, the idea here is to just bring it down barely less than 185. Don't bring the blood pressure down too low, because you do have to keep in mind that your patient may benefit from having high blood pressure to protect the brain, but certainly not above 185 because it would cause hemorrhage. Again, it's the recommendation is post alteplase. What is the blood pressure management? The goal is to keep the systolic less than 180 and diastolic less than 105 during the first 24 hours. And the recommendation is again use IV labetalol judiciously, liberally. And again, if not hydralazine, and either of those doesn't work, you can certainly consider continuing or starting the nicardipine drip at the rates that we previously This is our last slide, and again, some of the important things here. If you have a patient that is getting IV Altipless and you are unable to host your patient because of for whatever reason it may be the case, lack of medical coverage and so forth, please consider transferring the patients to the nearest primary stroke center where they can receive further workup of whether or not they need CT angiogram and eligibility for endovascular mechanical therapy, or if there is a thrombectomy capable hospital or a comprehensive center that is closer to you where further care can be given. I suggest that that transfer plan should be thought out early on in the process so we can save time. And we all understand time is brain. Please keep that in mind and have parallel processing about transfer arrangements while everything else is going on. That will be the best care for your patients. And again, what I would recommend is that if you have a patient that has either a hemorrhage in the form of intracerebral hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, or a large vessel occlusive stroke, certainly helps to seek a recommendation or advice from your neurologist in the appropriate location. And again, once you have the transfer plan in place, there are certain important things that would probably help with transition. Our recommendation is that some of the information should be available for the receiving hospital, the nurse or the provider, whoever may be the case. So information is not lost, and some of the things that we suggest should be accurately related or last known MELD status appears to be the most important one that we all are looking as a receiving center to see eligibility for endovascular thrombectomy and so on and so forth. NIH stroke skill pre and post would certainly help. Vital signs, is the blood pressure high, or is the patient on a cardipine drip? Certainly relevant information that the receiving hospital would benefit from knowing. And what kind of medications have the patient received? Is he intubated? Is he not intubated? And again, a short medical history doesn't hurt. The contact information for the family, I suggest, is also very, very important. And the reason I say that is I personally, as an interventionalist, have used this information and the transit time where the patient is being transferred from wherever they're coming from, the 1 hour or 45 minutes where I would call the family, consent them for the procedure if I think that's the thing that the patient needs. So we can cut short or door to needle times, door to thrombectomy times, door to recanalization times. So certainly that information would help passing on to the receiving hospital person as well. I think that ends our presentation, and I appreciate your opportunity to present to you.